On-the-scene coverage of ACC.13 is supported by Janssen Pharmaceuticals, Incorporated.
I'm Peter Block here at ACC.13 in San Francisco, and there is a lot of good stuff going on. A lot of late-breaking clinical trials, and I'm here with Dr. Paul Douglas. Paul is a country cardiologist from Atlanta. Not really, he's at the Atlanta Medical Center, chief of cardiology there. Paul and I have been friends for a long time. Paul, we were talking about the STREAM trial, this early fibrinolysis versus not doing a PCI immediately, particularly in some places where they couldn't do that. Tell me about the STREAM trial.
Well, this was an interesting trial, Peter, and this was a trial they randomized 1,000 patients in each group. One group got primary PCI, as we generally would do it. The other group got fibrinolytic therapy and the usual antiplatelet and antithrombotics. And then some of those patients they took to the cath lab. They needed angioplasty, they did it. If they didn't need angioplasty, then they measured the outcome.
Yeah, in the trial though, how did they figure out whether they needed angioplasty? What was the cut point there?
Yeah, it was based on what the lesion looked like when they got in TIMI flow, when they got to the cath lab. And then those people who they deemed, had less than TIMI 3 flow, then those patients went on to angioplasty.
I'm having a deja vu from the PAC trial, which is a 1990s trial, long before stents and all that other stuff. We gave a bunch of patients at that time half-dose thrombolysis. Some of them did not get it. They were randomized and took them all to the cath lab. And then if they had TIMI 2 or better flow, they didn't get a PCI. It turns out there was not much difference in outcomes. So tell me what happened here.
Well, and that's the same thing we saw in this trial as well, that the outcomes, the composite endpoint, though, death, myocardial infarction, stroke, were basically the same. There was no statistically difference in outcome. However, as you would expect, with fibrinolytic therapy, there was an increased risk of bleeding, and bleeding, particularly hemorrhagic stroke. And
so intracranial hemorrhage.
Exactly.
Not a good actor.
And that is a bad thing to happen. But the other thing that I think that we learned from this is that in those patients who you cannot, for some reason, get them to the cath lab in a timely manner, that this does offer us an alternative therapy for them, and you don't lose a whole lot in terms of a composite endpoint.
Tell me a little bit about the stroke issue, though. Is this mostly hemorrhagic stroke?
This is mostly hemorrhagic, and it was almost double the risk.
Okay.
So it's significant, and it's statistically significant, and it's double the risk from those patients that had primary PCI.
But tell me what the overall risk was in the whole study, somewhere around 1%, the usual kind of
we're talking
stroke risk.
0.5% with a primary PCI group, and then I think it was about 1.5 or so, or a little over 1 for the patients that got fibrinolytic therapy.
Okay, so Paul, you take care of patients every day, right? And you get lots of references and referrals and so forth. For the practicing cardiologist out there who's being called or has a patient that's either in a hospital that can or cannot do PCI, what's the message from this trial?
Well, I think one thing that we've learned, and that is, in those patients where there may be some barrier to getting them to the cath lab in a timely manner, that if you look at this trial, 2/3 of the folks who got fibrinolytic therapy really did not have to have a PCI at that point. So if there was a reason to delay any logistical problem, you don't lose a whole lot in terms of a composite endpoint. But of course, for those of us who do this every day, we really still feel that primary PCI is the best therapy for patients presenting with acute myocardial infarction.
But if you can't do it, it's not a bad deal.
If you can't do it, this is not a bad deal, but accept the fact that you may have a little small incremental risk of bleeding, and the bleeding may be significant, intracranial hemorrhage.
Okay, well, there you have it. There's going to be lots of good things coming up. Come back, see us again, and we'll have more information for you as we go forward at ACC.13.